Good morning, good afternoon, good evening, everybody. This is Dr. Anthony Chang, the founder of AI Med, and I'm truly very excited to see our panel today that is going to focus on the use of AI in pediatrics, but particularly pediatric imaging, which is such a big part of pediatrics. And I think this is truly an all-star cast, and I'm really excited about listening in on this amazing webinar. And my good friend and colleague, Dr. Sudan Desai, is a radiologist at Phoenix Children's. And I met him when he was still at Texas Children's and was really impressed with his insight into bringing artificial intelligence into pediatric imaging. So I can't think of a better chair for this panel than my good friend Sudan. So Sudan.
Well, thank you for the introduction, Anthony. And I'll sort of editorialize here a little bit that it is a distinct pleasure to be able to moderate the session with a number of just excellent people and experts in the field of pediatric imaging, as well as use cases of AI. So we will focus on implementation and some of the outcome strategies, and I think you'll hear a variety of perspectives and hopefully learn a lot from the session as well. Our panelists include Greg Zaharchuk, who is the founder of Subtle Medical, as well as a neuroradiologist at Stanford, Ellen Grant, who's the director of Fetal Neonatal Neuroimaging and Developmental Science at Boston Children's, Safwan Halaby, who's an associate professor at Northwestern and the director of Fetal Imaging at the Chicago Institute for Fetal Health, as well as Patrick Levy, who is a professor of pediatrics, a subspecialist in hematology oncology, and associate medical director for clinical affairs at UT Southwestern in Dallas. And I think one thing that strikes me as we introduce this panel is just the variety of the expertise in terms of clinical subspecialties, as well as the background that this group brings to the session. And as I said, I hope you enjoy the talks and learn a lot from the session. Please feel free to enter your questions in the chat. We'll address those after all of the speakers are complete. With that, I'll introduce our first speaker. So Dr. Greg Zaharchuk is an MD PhD. He's a professor of radiology and a practicing neuroradiologist at Stanford University. As mentioned, he is the founder of Subtle Medical. He's an expert in advanced imaging methods and particularly applied to patients with neurological disorders. I'll allow him to sort of expand on that as he desires, but with that, I'll turn it over to Dr. Zaharchuk. Thank you.
Thank you, Dr. Desai, for that nice introduction. I'm going to spend the next couple of minutes talking to you about the use of AI to reduce study duration and radiation dose in pediatric imaging. Let's see if I can figure out how to go forward. Great. So when I talk about radiology AI, I like to think of it from the patient's perspective. So typically one comes to the scanner, one has images acquired, they're then visualized in some way at the scanner perhaps. We might do analytics on them. Eventually, somebody will make a diagnosis and proper treatment will occur. And I think a lot of the advances in AI that we've seen have been on the far right of this diagram in interpretation, which is quite exciting. But I'm really going to talk to you more specifically about upstream AI, or the use of AI to improve the acquisition process, which is very relevant to pediatric imaging. So I want to start out talking about MRI. So in MRI, we don't have any radiation dose, but when you think about what's important, the important thing is time. And Bill Edelstein wrote this nice paper about some pretty good MRI practices. You might want to read through those and see if your site is doing these things. But one of the things that really strikes me is that he really thought that examination should be quite short, quite a bit shorter than most of our current imaging. And of course, from a pediatric perspective, this would be very helpful because it would offer the potential to perhaps reduce the use of sedation and general anesthesia in pediatrics. So how can we improve MR image quality? If we can improve MR image quality, we can potentially reduce imaging time duration. And there are two basic approaches. One starts from the sensor or case-based data, and one starts from images. Now, when we talk about the sensor data, there are a lot of advantages to using this. This is complex data. We can explore different ways to collect the imaging itself. And actually, radiologists and physicists know a lot about how to do this already. They've done parallel imaging and compressed sensing, so AI is not such a new beast. Now, one of the challenges from case-based data is that all vendors have proprietary data formats, such that if you develop an algorithm, it might not generalize between different scanner vendors. And of course, they can change their data formats at any time they want. So let's talk a little bit about one example of a case-based type mechanism for doing this. And I want to give the example of the variational network by Florian Noel and Kristen Hammernick, which was one of the first ones. And the basic idea was you started here on the left and you took a very sparse image that was collected very quickly, and you just zero fill it and you get this image with all these artifacts in it. And then essentially you take that image, you compare it to a gold standard reference of a high quality, fully sampled image, and then you model this reconstruction error through the use of a variational network, which uses a convolutional neural network typically. And this iterative process can lead to actually quite nice results. Here are some examples from their work in the knee, showing on the left parallel imaging, in the middle parallel imaging with compressed sensing, which is a more sparse technique, and then finally a deep learning method. And you can see quite excellent performance, speeding up the scans by a factor of 4. They also showed that this generalized, surprisingly, that if you trained on enough different imaging data parts, you could actually do this in different parts of the body. And here are a very wide range of images from musculoskeletal to brain, etc. Now, another way of doing this is to start from images. So these are generally magnitude images. So you lose the complex aspect of the data. But you can now frame the problem in more simple ways, similar to natural images. So you can think of these as denoising strategies or super resolution strategies. If you're in the image space, you have less proprietary data issues because all scanner manufacturers have to provide images. So in theory, this is a vendor neutral approach, and many places, of course, have different vendors or may want to change vendors. So it has certain advantages. So I want to give a short example of how this works, and I wanted to talk a little bit about arterial spin labeling, which is a method of measuring blood flow without contrast agents, which is actually used quite a bit, at least in our hospital, for pediatric neuroimaging. And the basic idea is that you image the brain with and without labeling of the spins in the blood of the neck, and then you subtract them, and you get a CBF map as shown in the bottom right. But the problem is that this tends to have very low signal to noise, so you end up doing a lot of signal averaging. So one approach would be to say, let's take a great image, let's take a long time to acquire it, maybe 8 minutes, which is quite long. It turns out that in real life, you might want to do a 2-minute series, which is very noisy, as shown here. But the idea with imaging is you can combine this with other data that perhaps you get for free as part of this. And you can essentially synthesize or teach a network how to produce a high quality image as shown here. And this is some of the first work we did a long time ago and showed that we could reduce the time to acquire these images quite significantly with less error. Now, another thing that you might be interested in doing is improving resolution. Most people know that acquiring high resolution MR is very challenging and takes a long period of time. And in fact, many patients, particularly pediatric patients, can't stay still. So if you could acquire a quicker low resolution image, such as the image in the center, you can train a network to produce a high resolution image as shown on the far right. And in this case, you could see that actually because you use a shorter time, you have less of an issue with patient motion, which is also quite important. Some validation studies have been done of this type of imaging. This is just one example I would show you in the spine, just demonstrating that deep learning-based denoising can offer the same or better SNR and fewer artifacts in the spine, despite speeding up the scan by about 50%. Let's shift and now talk a little about radiation dose and PET. So standard FDG PET actually comes with a pretty hefty radiation dose with an added cancer risk per study of 0.5 to 0.6%. Now, PET MRI can eliminate the CT component, but not all places have PET MRI yet. And the question is, can we use deep learning to reduce PET radiation further? Would this be helpful? So as I described before, it is possible to train a network to essentially learn the transform between high quality and low quality as shown here. And this is just an example in a young patient with breast cancer. Maybe this will run. I don't know if you can run the video for me there. Oops, maybe not. Okay, well, we'll show another example later on. One of the things to talk about with denoising, especially deep learning-based denoising, is we're not just talking about spatial smoothing. This is an example of a patient with a small liver metastasis, where that if you scan faster or alternatively move to lower dose, you don't lose that signal in the noise. It's actually retained, as shown in the far right. Now, just to show you an example, this is kind of the video that didn't play. This is a patient with osteosarcoma. And instead of going to lower dose, in this case, the scan was just performed more quickly. And you can see here on the far right is your gold standard image, the image that everyone wants to read. In the middle is a lower quality image acquired much more quickly. And as you can see here, by applying a FDA available algorithm, SubtlePET, you can actually improve the image quality. And importantly, for a quantitative technique like PET, you can retain the SUV values quite accurately in these regions. All right, I just want to talk about one study that was done at Stanford, looking at reduced dose and its effectiveness for assessing patients with lymphoma. This was a study of young lymphoma patients. They received already quite a low dose of FDG. And the idea was to examine multiple lower doses and then apply a deep learning algorithm to improve the quality and to look to see if that made any difference. So along the top row here are the doses being reduced over time. So you can see the noise increasing significantly. Down below are the images after the deep learning algorithm was applied. So the question is, how does this actually perform in real life for staging of lymphoma? And one of the things that they showed was that as you would expect, if you just reduce the dose, you have much more random nature of the images. So your SUV max will naturally go up. And so this will lead to mistakes in staging. And what they showed on the top was this was much more severe in the patients who just had the dose reduction, as opposed to those who had the dose reduction followed by the deep learning algorithm. And in fact, the conclusion of the study was that at 50% reduced dose, all the patients were classified into the same staging as with the 100% dose, but only if you used the deep learning model. So one question would be, how low can you go in terms of dose? We've been very interested in the idea of perhaps going to even 0 dose for some radiological examinations. This is an example of imaging in glioblastoma, where we looked at 3 MRI sequences, T1 post-contrast, T2 flare, and ASL, and we tried to predict the FDG study that they would get in these settings. And as we know, FDG metabolism is very related to blood flow, so you might think that this might have a chance of working. And in fact, if you synthesize the FDG PET, you get very similar images. In the top, in a lesion without recurrence, and in a study at the bottom, a lesion with recurrence. And people often ask, how is this possible? I just think that there's probably more information in the MR images, especially combined with an elegant algorithm, than we actually can see as human beings. So what are the challenges? Challenges remain. There are a lack of large publicly available data sets. I think some of the people on this call are doing great work to try to improve that. But again, it couldn't come more quickly for our patients. I think that when we talk about imaging-based AI, which is actually probably also true from AI for diagnosis, there's the potential for bias such that individual scanners or populations may behave differently. And then finally, the high cost of validating the quality of the algorithms, right? There are many edge cases. We can't necessarily study all of them. So at what point are we confident that these methods are not leading to any loss of data fidelity? The only way we figured out to do this is with multiple reader studies And unfortunately, these are quite expensive and laborious to perform. So in conclusion, I want to leave you with the thought that AI approaches are going to let us do things in radiology better than before, and maybe some that are completely new and quite useful. That scan time and dose reduction may be very early applications in this setting. And this is really an opportunity to change our common assumptions around imaging quality, speed, dose, and safety. And finally, as I think a lot of the other people in this panel will discuss, this will have significant benefits for all patients, but particularly pediatric patients. Thank you very much.
Thank you, Greg, for that insightful overview and discourse of what some of the subtle technologies can deliver for the imaging population as a whole and pediatrics specifically. There were a few questions. As I said, we'll hold those to the end of all speakers. And I'll take the opportunity now to introduce Dr. Ellen Grant. Dr. Grant is a professor of pediatrics and radiology at the Harvard Medical School. She is the founding director of the Fetal, Neonatal, Neuroimaging, and Developmental Science Center. The abbreviation is FNNDSC, which I pronounce FunDisc. She holds the Boston Children's Hospital Endowed Chair in Neonatology and serves as a clinical neuroradiologist at BCH. She's a senior fellow of the International Society of Magnetic Resonance in Medicine and sits on the board of scientific counselors for the National Institutes of Child Health and Human Development. As with that, I'll turn it over to Dr. Grant, who will be discussing her views on AI in pediatric radiology. Thank you.
Great. Thank you very much for that introduction. So I'm going to talk about some of the areas we've been working in AI, some of the potential benefits, including fast scanning, more efficient scanning, radiology decision support with fetal brain reconstruction, hypoxic ischemic encephalopathy lesion detection, and trying to triage normal versus abnormal scans across the lifetime. In addition, we've been developing new tools to better do fetal biometry and actually characterize fetal neurodevelopment. And then I'll end with a comment on the harder part, which is the everything else, and how to get these into the clinical workflow and some of the collaborations we've been developing to try to attack that specific issue. So as we've been collaborating with Greg, and you've heard about SubtleMR, we worked with him to gather 27 data sets, 12 that we used for training and 15 for test and evaluation. In the training data sets, we acquired the images at the standard time here, the minute 9 seconds, and then we trained, used a deep learning model to accelerate or use a faster acquisition, a 3x3 acquisition, and then with the enhancement, have the resulting images. So you can see what the comparison is. Very difficult to see the differences with a quarter of the time in terms of acquisition, which is tremendously important, particularly as Jack mentioned, for the pediatric population. And on Likert score 0 to 5, 3 experts couldn't really tell the difference between these two acquisitions. So we're very excited to continue collaborating to accelerate our acquisitions. We don't just do postnatal imaging, of course we do fetal imaging as well, and the efficiencies there are even worse in terms of there's a lot of motion slice to slice. So what we've done is we've hooked up an Ethernet, a GPU computer through an Ethernet hub to the scanner. And as the scans are acquired, images are sent to the computer, and we run a convolutional neural network on it to assess image quality. And the scores are acquired, and then what the scanner does is go back and reacquires the images that were poor quality. So here's an example of the images. The one on the left here had a low IQA score, quality score, so it was reacquired and met the criteria on the second acquisition. So this continues on until you complete the step, with of course a timeout to prevent continuous scanning. So we're hoping to increase the efficiency of scanning for fetuses with this approach. We also want to provide fetal brain reconstructions at the time of image interpretation. These are hard to do because there's a lot of manual intervention, but we've trained neural networks to extract the brain before we do the super resolution volume reconstruction. And then we've got algorithms that are convolutional neural nets that can segment the cortex and then give you the cortical surface reconstruction. So this is something we want in the clinical workflow as soon as possible to help inform our clinical reads. If we're lesion detection, hypoxic ischemic encephalopathy is a big challenge. So we've developed normal atlases, getting data sets from our clinical workflow. So any individual that has a concern for hypoxic ischemic injury, we can run Z-score maps. And then we put those into an algorithm using the Z-score maps and expert annotations to train a UNet to detect the lesions with the highest dice scores that have been provided to date. And the particular algorithm is showing pretty good generalizability across different scanners, but we are planning to deploy it to multiple different sites to test its generalizability. We are also working on decision support through brain age estimation. We've just published this brain age algorithm, which was built off of over 8,000 data sets from 0 to 97 years of age, using a 2-channel AI model where we looked at both global and local features to estimate brain age based on the MRI. The performance here is 2.7 years is the mean absolute error. And we want to do that. We have to characterize the performance on our normal in terms of what the distribution is, but here's an example of its potential looking at normal controls, adolescents and young adults with congenital heart disease, showing that there's a significantly accelerated aging in the congenital heart disease population. These same kind of algorithms we're developing for fetal brain age estimations, learning deep learning and multiple slices. We feed in the sagittal, axial, and coronal slices with test time augmentation. And what we find is that we get the highest performance of the different algorithms to date, with an error of less than 1 day in estimation of ages. We think this could be a wonderful complement to the ultrasound brain age estimations. And here's an example here where we compare the estimated or the absolute difference in age. The typical fetuses are here. Those with heterotopias, polymicrogyria, and microcephaly show significant differences from what the distribution is in normal. So we're hoping to put this into our clinical workflow to flag the clinicians when they need to pay more attention to that brain and to double check for abnormalities, to try to again normalize our scans and get everybody on the same page. Finally, we've been using or collaborating with the MIT group, developing algorithms to track fetal movement in EPI volumes. We've trained networks to track, say, here you've got the shoulder, elbow, wrist, for example. So we can get metrics on fetal motion, like angle around the movement change around the ankle and knees, as well as, since we're tracking, we continue to track, so we optimize the length of each limb, so we can also provide biometrics. So this is the length of the femur and the different data sets we've acquired to date. The solid line is in the what the reports are for ultrasound. So we think this is going to be a really accurate and way to provide biometry of not just femur, but all the different joints, or all the different limbs. Our measures are higher because we go joint to joint, not just measuring the shaft. So finally, just into the hard part is everything else. There's a growing number of AI algorithms, both the ones we've developed, other tools and tools that are industry we really want to use clinically, but we also want to remain very flexible so we can rapidly update and test novel algorithms as they are deployed or become available. So we need to constantly integrate these new tools into our clinical workflow. And with the complication that many of the tools are often computationally intensive and incompatible. For example, we need to run on different operating systems, are GPU-based or CPU-based, and we need to take care of those complexities. In addition, particularly in the pediatric population, we want to enable computation without sharing data so we can better understand some of the rare diseases that we deal with in pediatric centers. So what we've been working on for a number of years now with BU, Boston University, the Mass Open Cloud, Red Hat, MGHBCC is what we call the CRISP project. What this is an open platform that it connects directly to the PACS and can be set up to compute on whatever background computational infrastructure makes the most sense. The developer can easily package an app as a container, put it in the App Store, and then we can put it onto the platform. So for example, we've got FreeSurfer, and we're about to deploy the different metrics that I've showed you as well too into this platform. The CRISP administrator then sets up the workflow and makes sure it connects to the environments that it needs and the specific cloud or computational infrastructure. And then CRISP orchestrates the workflow, selects the batch and compute environment, pulls the data, and then provides the results back. And here's the interface as it is right now. You can track the workflow through the different nodes in the pipeline. These may be many stages in a pipeline or different plugins or apps that are run. When it finishes, you have a nice window here to see, for example, if you like the results. This is a brief server segmentation, and you can look at the results. If you like them, you can go to another node that gives you the quantitative analysis. We're in the midst of figuring out how to hook this up to our voice recognition system so that if it's the results that we approve, then we can integrate it into the dictated report. Finally, the last thing is trying to figure out how to work together across multiple sites. So we've been working with some top cryptographers that are based at Boston University and Red Hat, trying to come up with ways to share data across sites without, or share analysis without sharing data. The way the workflow works is we're designing it is the platform is running an app. It then goes through a multi-party computation orchestrator or a differential privacy orchestrator that then talks to the different environments in two different hospitals that are physically separated. Then there, with cryptography approaches, the two different data sets can share information that is encrypted, and then the results are provided back to the platform that is a computation on both sets of data. So it's a way to keep governance over your own data without having to give your data to somebody else. And I think this is very important as we start to figure out how we're moving forward, because a lot of these algorithms are not going to be fixed. They're going to have to be continually adapting to novel sequences or improved acquisition designs as we continue to move forward. So in summary, there's many potential benefits of AI that some of the things that we're working on I've outlined. The harder part is the everything else, and trying to work together as a community and how to solve that without getting vendor lock-in is something that we're really interested in exploring, as well as working with some non-commercial cloud solutions such as a mass open cloud, so that the data is always in our hands and not governed by a commercial entity. Thank you very much for the opportunity to speak.
Well, thank you, Ellen. Again, just an insightful and interesting discourse about some of the happenings and some of the technologies that are being developed, and we appreciate your insights. With that, we'll move on to Dr. Safwan Halabi. He's recently joined the faculty at Northwestern University as an associate professor of radiology. He is the vice chair of radiology informatics and the associate CMIO at Lurie Children's Hospital. He serves as the director of fetal imaging at the Chicago Institute for Fetal Health and currently is the chair of the RSNA Informatics Data Science Committee and serves as a board member for the Society for Imaging Informatics and Medicine. Dr. Halabi.
Thank you, Sudan. And I appreciate all of the panelists and humbled by all the amazing work, which is literally and figuratively mind-blowing. So I wanted to talk about the other stuff that Dr. Grant just mentioned, which is the hard part, right, is everything else. And this is just one example of what I'm going to talk about is just validating one tool. So many of you have heard of these bone age tools, a regression AI tool that helps determine, just similar to fetal brain age, pediatric bone age, which is essentially done by taking a radiograph of a hand and assessing, what the bone age is compared to an atlas, as you can see here in that previous image. These atlases are very old, and we need to have new normograms for them. But this is work done by Dr. Larson and others at Stanford that looked at developing an AI tool that predicted bone age and showed that early on, these tools are very similar to how a radiologist would review them, and they did very well. But how could we take this and actually get it out from the ivory tower to pediatric practices? And so we thought about implementing it clinically, and I wanted to talk about the difficulty of getting a tool out into clinical practice and also getting a multi-institutional randomized control trial, which recently just finished, and I want to show the conclusions of that. So things like IRB, data use agreements, consent, do you get patient consent? Do you need radiologist consent to use these tools from a research point of view? The interfaces, the workflow, and the AI model, all of these parts have to come together and be orchestrated to implement clinically. And the other part of it, the whole psychology of implementing these tools is that how do they affect the clinician? How does our practice change, and how will we have to train the future physician on these tools? So this randomized control trial, we took an experiment group, control group. One group got the AI result, and then the other group had to do the good old-fashioned interpretation and reporting. So this culminated in, so the group that got the AI algorithm had basically a pre-populated report here. And you can see here everything is, from the date of birth of the patient to the bone age, the chronological age, and the standard deviation was teed up, and they just had to basically validate and sign off. Now, the question is that, that looks very, very clean. I love this, beautiful kitchen. But what I'm going to discuss is how much mess that's in the background to even get to the point where we can implement this clinically and also validate that it actually works. So this was a multi-institutional trial. You can see here many of large pediatric institutions were represented. But you can see here the time it took, so IRBs, and you can see the data use agreement is in orange, privacy review, so on and so forth, how long it took to actually get one tool to be implemented at multiple sites. So the IRB was, the average duration was about 5 months. There was no central IRB. Every institution had to approve this research study. And also there was question on, do you need patient consent? So do we, upfront ask patients to allow their data to be used when they're imaged? The data use agreements average 4 months, a lot of legal rambling. And what's very interesting about pediatric settings is that they're very risk averse. So it sometimes takes even longer in a pediatric setting to get some of this data to be used and assessed. Privacy reviews, again, latency among information security, privacy offices, and lack of clarity in the process. Clinical integration. So again, every system has its own PACS, has its own speech recognition system, and how do you get SR DICOM information from the algorithm into the report directly? So all of that had to be assessed and customized for each group. And then how do you determine the differences from the AI group, from the groups that did it the good old-fashioned way, is that there was a manual extraction of interpretations of these reports. And so, and then the other piece is, how do you establish the gold standard to begin with? And so we had a panel of 4 radiologists for every single exam that was assessed. And you can see here, it was a lot of looking at bone ages. Sometimes I think I dreamt of bone ages or bone studies while doing this. As you can see here, some reviewed 600 studies and labeled them. So, this culminated into this RCT. Again, it was probably one of the first prospective multi-center randomized control trial for an AI algorithm in radiology. So it was a pixel-based tool. And these are some of the outcomes. So we had 93 radiologists at 6 centers without and with AI, as you can see here. So the group that had without, there were about 740 radiographs versus 790 with the AI algorithm. And it did show improvement. And I think what we always hear about is the radiologist with the AI system is going to be better than the radiologist alone. So, one is that these systems will be changing the way we practice, and we will be doing it more efficiently and more accurately. Also, the efficiency, so that we were able to get basically a better prediction in a quicker amount of time. Now, one of the interesting things was there was one center where their accuracy decreased with the AI algorithm. And I think this is one of the biggest things to mention is not only the automation bias, but will the AI, its average, bring down the average of higher performing groups or higher performing radiologists? So if you are a very good person at neuroimaging or bone ages, will you go down to the level of AI once you start trusting it more and more over time? So the RCT reflections are that the integration was not the hardest part in this. It was the paperwork, because it was a research study. But again, as Dr. Grant and Dr. Zaharchuk mentioned, is getting this into practice and getting vendors and also industry to get on board with some of these tools is, one, they have to be integrated seamlessly. And again, this is just one tool. How do we orchestrate multiple other tools, including lung lesions, systematic review of cancer tumor over time, and so on and so forth. So we're just in the nascent period. So the takeaways are we need a layer of this technical and legal infrastructure across institutions to support this validation of AI models at scale. I think that we will continue to have to develop these validation studies for these tools, especially in the setting of rare diseases, or even in a pediatric setting where it is a team sport, and we need a volume of data to create these algorithms and also to validate them. And then standards, which is one of my passions right now, is trying to get data standards, sharing standards. The implementation science is going to be very important, and also optimization. So once you do put a tool in, who's responsible for it? Who's responsible for making it better? Who's responsible to know when it goes off the rails? And also the validation piece. Is there going to be a whole new science and infrastructure? Is it going to fall under the IS group? Is it going to fall under quality safety? Is it going to be the responsibility of the radiologists to do all this? And then the other takeaways are, we need to look at what are the significant clinical needs that can be addressed by AI. I think the fetal biometry is absolutely phenomenal. The reducing of dose and improving movement artifact or motion artifact for pediatric children to reduce sedation, to reduce scan time, and to reduce radiation is ultimately what we'd love to see. So that is a huge clinical need, and the technology must perform at least as well as the existing standard approach. So again, I think this bone age showed that it is consistent with the existing standard approach and probably more reliable over time, because the AI algorithm does not get tired, and it reacts to the images the same way at 3 a.m. versus 3 p.m. We need substantial clinical testing to validate this new technology, and these technologies should provide improvement. So we will have to assess whether outcomes are improved. I have a whole different talk on the disparities that may come out of AI implementation, the quality of life, practicality and use, and reducing medical costs, and also a coordinated approach between multiple stakeholders. So again, this will require data scientists, it will require physicians, it will require health systems and payers and government, essentially. And with that, I'll pass it on to Sudhin and Dr. Levy. Thank you.
Well, thank you, Safwan. Again, I think we're starting to put some of the necessary frameworks around the more details that we're hearing in AI. I'm particularly excited to hear from Dr. Patrick Levy, who is a professor of pediatrics at the University of Texas Southwestern Medical Center in Dallas. He is a pediatric oncologist and is the Associate Medical Director of Clinical Affairs for the Center for Cancer and Blood Disorders at Children's Medical Center. I think what's illustrative for me is that although this is a session labeled as AI in pediatric imaging, we certainly see the width and breadth of diversity that actually entails. And one of the questions that we may get to is how these changes impact our other clinical colleagues. And I'm hoping Dr. Levy will shed some insights on his work and what that means for pediatric imaging moving forward.
So hello, and thank you for the invitation to join this session today. It really is quite a privilege to be a speaker after those three outstanding presentations. The presentation I'll make is focused on a single problem within the field of pediatric oncology. I'm a sarcoma expert and care for a lot of patients, typically teenagers with osteosarcoma. While it's the commonest bone sarcoma, all of these tumors are, of course, exquisitely rare. In osteosarcoma, we have a problem, and let me just get to, here we go. One of the difficulties is that it's a hard calcified tumor, typically in a long bone. Distal femur is the most common site. And as a hard calcified tumor, it doesn't shrink in response to effective chemotherapy. So a soft tissue tumor will shrink. We'll know that the chemotherapy is working. That turns out to be very important in most chemotherapy treatment strategies, but it's much more difficult in osteosarcoma. In fact, the only real way to know if the treatment that we're using is working is at the time of surgical resection, because all these patients undergo surgical resection of their tumors, is for the pathologist to evaluate the tumor and determine the amount of tumor necrosis present, and it actually is quantified. And those patients who have more than 90% tumor necrosis find themselves in a favorable risk group. Those who have less than 90% tumor necrosis, unfavorable. It's become a dichotomous variable, although it truly is not actually dichotomous, of course. So within this field of oncology and within the difficulty of necrosis interpretation, one problem, of course, is that it becomes available only after the time of surgery. It is available only for a single plane of a pretty large tumor, and this will become clear as I go through this talk, and it becomes a fairly cumbersome procedure. The thesis for a project that's gone on for the last 6 years is to try and merge what we know about the use of histology with AI tools and digital imaging within MRI scan that's clinically available for all patients, to try and optimize this interpretation. All right, so the way we approach this is we took an archival data set of histology slides from 50 patients who underwent tumor resection at Children's Medical Center, Dallas, over a period of about 15 or 20 years. And we digitized all these histology slides. And now, of course, the digitalization technology is superb because it retains cellular and even subcellular detail within magnified images. Each individual glass slide, when it's magnified on a digital platform, becomes an image tile. We generated a fairly easy to use annotation software tool. So pathologists could actually, in a pretty quick way, annotate an individual tile by color coding and just drawing areas around a particular area of a tile that might represent a necrotic area of tumor, or a area that represents non-tumor, or an area that represents viable tumor. And in a fairly quick way, pathologists could annotate this series of tiles. And then, of course, we can submit annotated tiles and previously unreviewed tiles into an image classifier. And so we did this and published data a few years ago describing a proof of principle experience using 40 slides, which represented the heterogeneity of osteosarcoma, both histologic subtypes and heterogeneity within subtypes, using 1,200 tiles broken down in this fairly standard way of training and data sets. And we generated a three-dimensional receiver operator characteristic with a fair degree of confidence in our ability to separate areas of tissue or tumor necrosis, areas of tumor viability, from areas that didn't represent tumor at all, but were in the resected specimen. And we did this in a three-dimensional way because actually clinically, a pathologist takes a whole glass slide and first determines whether it's tumor or not, and only then determines whether the tumor is viable or not. So to bring this to the imaging platform in terms of radiology imaging, the next few slides will describe a series of steps that are critical to that. This is simply just a photocopy of an image of a resected specimen. So one can imagine that this is a distal femur, which it is, which is bivalved in a coronal plane, which it is, and which is overlaid by a grid, which may be difficult to see, but there's small squares overlaying this picture. And from each of those areas are taken individual histology slides. And of course, these are all digitized. But digitized images can be inverted, can be rotated. And so we decided that it was important to realign all these images and essentially recreate through an algorithm, which we described many years ago, the same plane. So we can recreate the plane of interest from where all these histology slides are taken. That becomes important. But as a preface, if we can recreate the plane of interest, and we know that we can, with confidence, classify tumor necrosis from viable tumor from non-tumor at a tile level, well, then it doesn't take a rocket scientist to imagine we can expand that to a whole slide level and expand that to a plane level, which is what these graphics demonstrate. So interestingly, then, if you take a bivalved tumor or a bivalved bone with a tumor within, and you know the plane from which you took all of the histology slides, what we want to do is co-register this plane to the correct plane within a three-dimensional MR. And this takes several steps, some of which I'll iterate here for you by way of example. The first step is to use three-dimensional molds which are created from three-dimensional MRI images, within which we place a resected piece of bone, and those three-dimensional molds are identifiable to the pathologist as he or she separates or bivalves, the tumor along the plane of interest that represents the largest surface area of tumor. This, of course, is predicated upon a three-dimensional MR to identify that largest surface area. And then using a control point mapping procedure, we can generate some confidence that we can co-register the plane of interest from MRI to histology, and then visually demonstrate that there's an ability to overlay these planes of interest as demonstrated with these graphics. And while there are many things that I'm not describing here for the sake of time, they can easily be imagined that there's a significant amount of pre-processing for images, segmentation of images, and then MRI sequence alignment, which has to be done. But if that's envisioned as convincing enough, then you can now imagine that depending on which MRI sequence you take, be it post-contrast or a T1 weighted image or a STIR or a diffusion weighted image represented by ADC or any one of a variety of dynamic contrast enhanced image acquisition parameters, we can begin to train a machine learning algorithm to subtract or extract features which identify necrosis from a viable tumor. And of course, each of the rows here are a variety of features that can be summarized by any one of a variety of terms. But this heat map essentially demonstrates that using histology as the ground truth, we can begin to identify with a fair degree of at least statistical confidence that we can separate tumor necrosis from tumor viable areas within a voxel or an area of interest on a MRI that's co-registered to the source of truth from the same voxel or area of interest from the plane of histology. And what that allows us to do actually now is using MRI scans to start to create single plane tissue classified images or three-dimensional tissue classified images. And so these are dependent on the MRI that's selected or the sequence that's selected or the combination of sequences that's selected. We can get three-dimensional pictures of a tumor and where within that three-dimensional image there may be viable tissue or there may be non-tumor. This turns out to be important, or we think likely to be important, in planning local control for osteosarcoma. And this is a paper that's just recently been accepted for peer-reviewed publication. So there are limits to the data that I've shown you here. This is from a fairly small set of patients. This is from a single institution without opportunity yet to validate. And this, of course, is from a single MRI platform. And there's importance to take this algorithm to other platforms. But I'll stop by just acknowledging my co-investigators at both UT Southwestern and UT Dallas, along with investigators at Children's Health and the funding sources for the last few years, and of course the patients and families who participated in this research.
Well, thank you, Patrick. And we do have some questions. What I may do at this time is invite all the panelists to turn on their cameras and have somewhat of a virtual panel, if we will. One question that was posed directly to Dr. Zaharchuk how can we be sure that the training data used for either case-based or image-based denoising has enough clinical variation in it to represent the entirety of potential variations in anatomy in the whole population? An example, cardiac MRI and congenital heart disease, it's often possible to see things, quote, we've never seen before. So how do we know that the algorithm didn't add or remove anatomy of physiological features or as a result of the denoising process?
Yeah, I mean, this is a great question. I mean, this gets to the limitation that I tried to describe in my talk, which was the need for very large reader studies to capture as much as we potentially can. I would say that one of the important things to realize is that, and I think people forget sometimes, is that images are just images, right? So images are useful insofar as they can help us towards a diagnosis or improve care for a patient. You know, it's really only kind of habit that says that we should image patients for an hour. If we wanted to image patients for 24 hours, if they're willing to sit there for us, you know, we might see a lot more. So it really comes down to where you want to live on that spectrum, right? I mean, in some sense, the image is a useful, I like to say, a useful hallucination that we can use. So just fundamentally answering that question, I think, is very difficult for any algorithm, including deterministic type algorithms. I think only by doing large studies and by evaluating in diverse populations do you get confidence with anything. I mean, that's how the early days of MRI started, I would say.
Okay, and I may follow that up quickly with another question for you, Greg. You know, have you had opportunity, and I think this is of particular relevance to the pediatric imaging space as it goes to some of these advanced imaging studies, which is, have you had opportunity to actually look at reduction in overall use of anesthetic, either as time or maybe more importantly from, and this probably would take, you know, larger patient samples from a complication or morbidity point of view. Is that something that you guys have objective evaluations for?
So the specific question of whether faster scanning protocols can reduce anesthesia, I think that point has been shown, and I think it's been shown very nicely from the group at Boston Children's, actually, that that is true. It's hard to imagine that the method with which you did that would necessarily impact that potential benefit in terms of reduced morbidity, mortality. I think the draw of deep learning is the fact that, you know, typically when you reduce protocol duration, you're compromising, right? You're compromising on quality at some level. And the promise of deep learning is that through an experience-based algorithm, the amount of degradation of the image is minimized. So you should get the same benefits. But I will say that specifically, have we taken these algorithms and run them and demonstrated that, in fact, there's reduced morbidity and mortality for this? I would say no, but we're quite welcome to working with different groups that would like to implement this. And I'm very inspired by Dr. Halabi's clinical trial and whether we could do something similar to that with one of the pediatric institutions that does this routinely, because I do think this is a huge issue, not only for the patients and safety, but also for the institution. I think it leads to real inefficiencies, a lot of extra work, and potentially a lot of loss of, you end up rationing imaging essentially because you can't do it in everyone. So very open to those kind of studies with this new technology, but there's no reason to suspect that it wouldn't perform at least as well as those using, essentially no technology.
Yeah, I think that's maybe an inherently obvious point to those of us in the space and in pediatric imaging, but I think it's useful for the audience members to sort of hear that directly, which is, in kids in particular at these pediatric institutions, we're constantly looking for these ways to reduce morbidity, and that can take many different shapes and forms. And certainly leveraging these types of technologies is an excellent step in the right direction. As we await for more questions from the audience, I may ask one kind of to the panel in general, and particularly of interest again to sort of hear Dr. Levy, as this is somewhat of a question directed at radiologists, but may lend itself to a non-radiologist view, which is one of the knocks, of course, inherent within radiology to the use of advanced imaging technologies and AI in particular is that it may, quote unquote, lend the radiologist obsolete. So there's discussions around autonomous AI and things like that. But in listening to some of the conversation of today, potentially we're looking to flip the script, which is, do these technologies allow radiologists perhaps to be more clinically relevant and patient-facing as a result of having the ability to understand these developed technologies and how best to discuss them with the patient. And again, maybe we start with the radiologists on the panel and then turn it over to Dr. Levy for his thoughts on that.
I'll take a quick stab at that. One is, seeing Dr. Levy's work, even just osteosarcoma, it's a huge team effort to try to get signal from noise, right? You see the necrosis, you see the radiation effects or the chemotherapy effects, but how do we, maybe AI could decipher that there are areas of abnormalities, but how do we then bring that and handhold the patients through that whole process and say, this is what the AI tool is showing us, this is my experience, these are what the drugs are doing, and also we didn't talk about the whole precision health movement, right? That's what we're essentially trying to do. And if you take the human component out of that, I think that there would be, things will not go very smoothly. I think that the physicians and the people that are doing this are the glue. And one of the things I mentioned in my talk was that I do feel like there will be a new potential specialty where we have super diagnosticians or some higher level of diagnostics where you combine pathology, radiogenomics, and basic clinical care to effectively treat these patients in the best way possible. That's just my 2 cents.
Maybe to build on that, I think we learned our lesson from the Watson experiment that you need to have a human in the loop. So I think what AI does is gives you more information to think more deeply. So we can't just look at an image and say, oh, there's a lesion in the brain. We're going to have all this other dynamic information and information about genetics, patients, populations. We actually have to synthesize a large amount of data together, understand it and interpret it. So I feel it's kind of elevating us to a higher level of thinking. Instead of playing Where's Waldo, we're actually trying to understand mechanisms and the whole big picture of what is happening and how genetics are, a risk factor or environment is a risk factor, and how to pull those into an environment that we can have all that data in front of us at the same time. So I see us as a potential ultimate synthesizer of huge amounts of data, not just imaging and clinical record, but social, data that comes from where the person lives, where they travel. So I think it's the beginning of a data age, and we're poised as being used to interacting with data scientists and physicists and PhDs to really integrate and push that area forward.
Maybe quickly,
I guess as then the non-radiologist, I would say that in part there's no question the importance of the human being who meets the patient to be able to explain to the patient, but how the physician explains to a patient assumes that the physician actually understands. There's a lot of nuance here and detail here that essentially many, if not most, of the physicians who are in front of patients actually don't really get themselves. So we got a lot of work to do.
The good news is that the computers are more patient than the humans. So, Patrick, thank you for being such an ardent supporter of AI from the very beginning when we first met about 5-6 years ago. Sudan, for your friendship and your support as well, and your good work. Ellen, good to meet you and looking forward to working with you for the Pediatric AI group. Safwan, thank you for your support and your willingness to step up and help with the Pediatric AI group. And Greg, thank you, and Subtle Medical for your support of this webinar. And just what a fantastic morning. And I think pediatrics is well on its way. And just as a reminder, this is great timing for this session because yesterday our hospital just accepted an edge server to try to have machine-to-machine communication with Stanford. So Greg, you might be hearing about on your campus. So the beginning of a pediatric internet, and hopefully we can all communicate with each other continuously rather than just at webinars like this. So with that, I want to thank everyone for being here today as well, our attendees. And back to Alexis for an announcement about the Global Summit. Alexis?
Thanks, Anthony. And just to reiterate, thanks so much to our great panelists for a wonderful session there. Yeah, Anthony, as you mentioned, there's more tomorrow. We've got a panel of senior executives from Palomar Health, Novant, Alignment Healthcare, City of Hope, and IQVIA discussing the strategic approach required in order to deliver success in AI projects. If you're not registered for that, head to ai-med.io now to book your place. And indeed, we will be back live in California in January for more excellent conversations and connections in person. Again, don't forget to book your place. We're looking forward to seeing everybody there. For now, we'll see you again tomorrow for the last in the present series of the Clinician series. Thanks again to everyone and enjoy the rest of your day. Goodbye now.